morning, everyone, to a very chilly morning. And today I'm Vastikta Vats on behalf of Intas Oncology, welcoming you all to today's MHG webinar session. Today's topic is infection prevention and control. Firstly, I would like to thank Dr. M.B. Agarwal sir for giving us this opportunity so that we all could connect and we all could share our insights and discuss on such interesting topics. Let me take a moment to welcome.
You're muted, Dr. Vastavikta.
Sorry, sir. Is it better now?
Yeah.
Okay. Let me take a moment to welcome our today's moderator, Dr. Amit Khurana, sir. Dr. Amit Khurana, as we all know, is a highly skilled and experienced hemato-oncologist with a decade of experience in this particular field. He is also has a fellowship in bone marrow transplantation, clinical hematology, and is a clinical expert in managing these hematological and hemato-oncological malignancies. He's also experienced in performing bone marrow aspirations, bone marrow biopsy, and other hematological procedures. And thank you, sir, for giving us your time. And I would request you to welcome our today's speaker, Dr. Arpita Bhattacharya, and take forward the session.
Thank you, Vastavikta. Let me share the screen. You'll have to unscroll your screen first. Yeah, thank you. Well, very good morning to all of you and good afternoon and good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Arpita Bhattacharya from TMC Kolkata, and she's going to lecture us on infection prevention and control. This webinar is brought to you by Mumbai Hematology Group, supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and team Intas, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Kirti Sapnis from Mumbai. Our guest speaker for the day, Dr. Arpita Bhattacharya from Bhubaneswar. All our discussants who are themselves very eminent adult as well as pediatric hematologists and medical oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give flavor of our next weekend activities. Next Saturday, that is 20th of December 2024 from 7 p.m. Indian Standard Time and 7:30 a.m. Central Time. We have Dr. Nazima Gankat from USA speaking to us on venetoclax in AML beyond VIALE-A trial. And the following date, it is 29th December 2024 from 10:30 a.m. Indian Standard Time. We have got two speakers. The first speaker is by Dr. Nitin Sood from Gurugram speaking to us on a decade of real-world experience of Reditux. And following him, we have got another speaker, Dr. Neha Kamle from Pune speaking to us on diagnostic conundrums in myelodysplastic neoplasms and newer modalities of testing. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Anil Singhvi from CHL Hospital Indore, Dr. Ankur Ahuja from AFMC Pune, Colonel Dr. Ashok Meshram from Command Hospital Kolkata, Dr. Bilal Kazi from Apollo Multispeciality Hospital Kolkata, Dr. Devapriya Mondal from Fortis and SGCCRI Kolkata, Dr. Dhyaneshwar Upase from New Life Hematology Center Wakad Pune, Dr. Kartika KV from Esther MIMS Calicut, Dr. Kunal Goel from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai, Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bengaluru, Dr. Nadim Shoket from American Oncology Institute, Jammu and Kashmir, Dr. Narendra Agrawal from Rajiv Gandhi Cancer Institute, New Delhi, Dr. Naveen Kakkar from Maharishi Markandeshwar Medical College and Hospital, Himachal Pradesh, Dr. Neha Kamle from Dr. D.Y. Patil Medical College Hospital and Research Center, Pune, Dr. Priyanka Samal from IMS and Some Hospital, Bhubaneswar, Dr. Rajat Pincha from Tata Medical Center, Kolkata, Dr. Rashmi Kushwaha from King's George Medical University, Lucknow, Dr. Riya Balikar from Vokhat Hospital, Nagpur, Dr. Rizwan Javed from Tata Medical Center, Kolkata, Dr. Sanjeev from SGPGI, Lucknow, Dr. Satish Kumar A from Manipal Hospital, Bengaluru, Lieutenant Colonel Dr. Shilpi Saxena from Haryana, Dr. Saurya Ghosh from Tata Medical Center, Kolkata, Dr. Siddesh Kalantri from Blood Care Hematology Clinic, Nashik, Dr. Sonali Mohapatra from AIIMS, Bhubaneswar, Dr. Suhani Barbuyan from Dr. B. Barua Cancer Institute, Guwahati, Dr. Vijay Tilak from Varanasi, Dr. Vipul Sheth from RGCIRC Delhi. And now it's time to introduce our special guest and the chief guest for the day. We have with us Dr. Kirti Sabnis from Mumbai. Dr. Kirti Sabnis is consultant in infectious disease, Fortis Hospitals, Mulund, Mumbai. It's my privilege to welcome Dr. Kirti Sabnis from Mumbai and to inaugurate our webinar and give some words of wisdom. I stop over here. Over to you, Dr. Kirti Sabnis.
Really, thanks, Dr. Khurana, for this great introduction and giving me the opportunity to share my 2 bits on today's series on infection prevention and control. So it is really a chilly Sunday morning, and it's good to see people who are interested in a very important aspect of hematology, which is also an infection control, which is nothing to actually do with actual hematology treatment. So as we know, the history of hematology dates back to ancient Egypt, and actually the major ground breakthrough which happened was by Anton van Leeuwenhoek, which actually saw in, I think, 1642 an RBCs for the first time under a microscope. If we go through the last 50 years, we have witnessed a paradigm shift in the treatments which hematologists could offer with that time and now. For example, CML for that matter, which has given really a hope and survival to 360-degree and long-term survival. So we have come from where we used to diagnose from lab-based to a next-gen sequencing in last almost 20 years, and which has the next-gen sequencing is taking over majority of the diagnostic and therapeutic decisions which a hematologist is making. I was fortunate enough as my undergraduate training and a postgraduate training to be a part of CMC Vellore, where I worked with Dr. Vikram and Dr. Biju. So got a flavor of hematology, but afterwards shifted to infectious disease. So infectious disease also has a lot of next gene sequencing, which we offer to for a rapid diagnostics, which is really important for patients when we treat mainly for neutropenics and which we treat for hematological malignancies and transplants. So definitely it is taking over majority of the field, but it is very important aspect which we are going to discuss today of infection prevention and control, because it forms a major pillar for in any hematological unit. So as a team, in where I work now in Fortis with Dr. Sanyal and Dr. Hamza and Dr. Priyanka, we have a team which looks into. So I think the major focus today, which we need to look into, is a team approach, because it's not, it will be difficult for a single person to manage a complex hematological problems, deciding the treatment and giving a good outputs, because we current gram negative resistance which we are facing, or gram positive resistance which we are facing, for which an infection prevention forms a major pillar. And it's a team which, in infection prevention also, it's a team which works with a microbiologist, with an infectious disease physician, and we need equally empowered nursing, which is at the bedside for a good infection control. So definitely for a future of hematology, it's bright for young students who are aspiring to become starting your own unit and become a hematologist. It's definitely full of complex disorders, but also it requires a team approach, because there are multiple complex problems, not only hematological but non-hematological, we need to sort out. Definitely as a future which is bright for embracing new changes, nurturing the curiosity, and definitely we should not lose our sight, which gives an impact for the human lives. So I don't want to stand between the lecture, which is, and introduction of our speaker. So I will end my talk with the introduction with my with a small few words by Nobel William Osler. The practice of medicine is not an art. It's not a trade. It's a calling. It's not a business. It's a calling in which your heart will be excited equally as with your head. So often the best part of your work will have nothing to do with potions and powders, but with the exercise of influence of a strong over a weak, of the righteous over the wicked, and wise upon a foolish. So I think it should give us a food for thought for a weekend. I hand over to Dr. Khurana for further discussion.
Thank you, Dr. Kirti Sabnis, for that wonderful words of wisdom. That was superb and fantastic. Let me share the screen again. Now is the time to introduce our guest speaker for the day. We have with us Dr. Arpita Bhattacharya from TMC, Kolkata. Dr. Arpita Bhattacharya is Senior Consultant Head, Department of Pediatric Hematology Oncology, Infection Control Officer, Tata Medical Center, Kolkata. She deals with solid tumors and with a lead in retinoblastoma, neuroblastoma, RMS, abdominal tumors, as well as she also has a role in supportive care in pediatric oncology, as well as infection prevention and control. And today she's with us and she's going to lecture us on infection prevention and control. Well, thank you so much. I stop over here. Over to you, ma'am.
Good morning from Kolkata. Thank you so much, MHG, for giving me this opportunity to talk about infection prevention and control. Could we just go back to my first slide, please? I'm having somebody else share the slides with me for me because of a technical glitch. And I'm not very good at this, really. So could we just go to the first slide, please? That is wonderful. Thank you. Okay, so this is not so much as a lecture as a journey, because like many of us, when we are hematologists or oncologists, we look at the patient, we look at the cancer, we leave the supportive care to other people. Well, the thing is that to have a patient with cancer is hard enough. I am a pediatric oncologist. It's very difficult when you lose a child to cancer. But it is 100 times more difficult when I lose a child to something that could have been prevented, and that is an infection. So every oncology center, every hematology center has a robust infection prevention and control program. But as hematologists and oncologists, often we do not know a lot about it. I didn't know before I really started taking an interest in this about 5 or 6 years ago. So I would like to begin by saying that each of one of us needs to see ourselves as infection preventionists. We cannot give patients infections they did not have. And we have to be safe ourselves and keep our families safe. So we cannot take infections home to our families. Next one, please. Next slide. Okay, so all of us as oncologists, we need to know a few things. One is, what are the risk factors? Why our patients are so vulnerable? What gives them these infections? What are the modes of transmission of these infections? Every day we hear about standard precautions without really giving it much attention. But today we are going to discuss a little bit about standard precautions and what they are and what transmission-based precautions are. So because of transmission, the disease is spreading from one patient to another, we need to know the sources, how they are transmitted, and thus comes our preventionist roles. A little bit about aseptic non-touch techniques, a little bit about healthcare-associated infections, because this is the most important thing that we can prevent and we can save our patients. We need to take care of ourselves as well. So we need to know a little bit about post-exposure prophylaxis. What are the procedures that are more dangerous than others? That is, what are the exposure-prone procedures? We need to know a little bit about what happens to us if we do get exposed. How do we keep ourselves safe? So a little bit about staff health, which every large hospital has. And as infection preventionists and oncologists and hematologists, we also need to keep ourselves safe. So we need to know what vaccinations we need to have so that we don't get those infections, we don't give those infections to our families, and we don't give those infections to our patients. The next one, please. This is really simple, common risk factors for infection. So there are factors which are good, there are factors which are bad. So there are factors which contribute to infections. The most important of which is the hospital environment. All of us know that it is much safer for the patient to be at home than in the hospital. because the hospital is full of patients. All the patients are full of bugs, and those bugs are crawling about in the hospital, no matter how clean the hospital looks from outside. The longer the hospital stay, the more prone the patient becomes to picking up these infections. And because a hospital is not just full of bugs, it's also full of antimicrobials. So the bugs that are found in the hospital are more often than not resistant to many of the antimicrobials that we use. And as practicing hematologists and oncologists, all of us are familiar with multi-drug resistant organisms and the havoc that creates amongst the outcome of our patients. We know that as oncologists, all our patients are immunocompromised and they are much more prone to infections, be it bacterial, viral, fungal, sometimes even parasitic. Some of those we can prevent, but most of those, are we able to prevent them? Let's discuss. If a patient has medical devices, which many of our patients do, they have implanted devices like ports or Hickman lines or PICC lines. Sometimes they have stoma, they have trachees. So they are, again, harboring things which can get colonized really easily with bacteria and cause disease in them. Inpatient status, obviously, it is much better to treat patients on an outpatient or a daycare basis. And if the patient has comorbidities, we all know that a patient with a cancer who also has COPD is much more prone to getting a hospital-acquired pneumonia, so on and so forth. So as opposed to these terrible things, what are the factors that contribute to positive treatment outcome? So these would be good hygiene, community support. So the patients should have a place in the community that is safe. Immunization. So if all of us are immunized, say against influenza, the rainy season in our country is a flu season, and all of us should be able to say that wherever that patient got influenza from, it was not from me because I am vaccinated. Outpatient care as opposed to inpatient care, no device use as opposed to having implanted devices. If the comorbidities are well managed, say a patient has got uncontrolled diabetes, then you're in trouble, aren't you, with your patient? So good management of comorbidities, shorter stay in the hospital, minimal interventions. But above everything is whether or not the hospital has a robust IPC or infection prevention and control system. So next one, please. What are the common sources of infection in a hospital? So a hospital, as I said, is literally crawling with bugs. Every surface of the hospital, again, no matter what the cleaning protocols might be, are covered with bacteria. Beginning from the intensive care unit to the washroom, there are bacteria everywhere. How are these bacteria spreading? There are fungal spores in the air. They can spread through blood products. They can spread through food and water contamination. They can spread through unsafe infection practices. But most important of all, they spread through hands, mostly hands of the healthcare workers. That is us. So we need to pay attention to hand hygiene more than anything else if we are to prevent infections in our patients. Next slide, please. Before we say that what spreads the infection, let us just see what keeps our hospitals safe. We are working in safe hospitals without really finding out how people are working in the background to keep things going so that patients don't die from infections that they are getting in the hospitals. So beginning from the Central Sterile Supplies Department, which gives you all the sterile instruments that you use, supply chain management. So whenever you extend a hand, you can get a sterile instrument in your hand. But the CSSD is working behind the screens to supply these, to supply safe linen with the laundry. The hospitals also have ventilation and air conditioning system. There would be scientific officers in many hospitals who also do environmental quality control. So the air quality, especially when the hospital is air conditioned, you can see that the bugs can go on circulating through the ventilation system. Ours is a hot and a humid country. So temperature regulation is really very important because we know that bacteria love warmth, and they love humidity. So do fungi, unfortunately. All hospitals, no matter where they are, always have some construction work or repair work going on here or there. And what does that mean? That means more and more fungal spores in the air, aspergillus especially, sometimes muco, which we are inhaling without knowing. We are immunocompetent, but our patients are not, and they are catching these infections. So the hospital ventilation and air conditioning system has to be extremely robust to keep the patients safe. The hospital has a safe water treatment plant, so all the water that is found in taps in hospitals should be safe because we are washing our hands in that water, so that water cannot be contaminated. Every now and then we hear of Pseudomonas outbreak in hospitals, and where does that Pseudomonas come from? It comes from the water that is used for washing hands. The kitchen that supplies safe food to the patients, because if a patient is in hospital and gets an infection from the kitchen, that is not a very good thing. Housekeeping is working tirelessly all the time to keep all the surfaces safe. They use their protocols to keep clean the surfaces. That's why our patients are not dying of C. diff infections or other MDROs. Very, very important is the biomedical waste management. When I was a medical student, this was something that was quite unheard of. Well, I was a medical student a very long time ago, but now all hospitals, by government regulation, must have a robust and solid biomedical waste management system. So the waste has to be segregated at source. So all of us, when we are working in the hospital, we've seen the black bins, the red bins, the yellow bins. We have seen the sharps boxes. So it is really important we know what they stand for, which waste to dispose where. And a little bit knowledge about, where all this is going, because we just drop our used gloves into the bin, but then we don't know where it is going, whether it is being disposed of safely or not. So these are important and very interesting things that keeps our hospitals and our patients safe. Next slide, please. Now, let us just talk about standard precautions. This is something that we are hearing about absolutely all the time, but do we know it? The thing that I'm going to talk about most is hand hygiene. So I'm just going to leave it till the end, but let us just go to appropriate PPE because we know we've all been through the COVID times and we know the importance of PPE and how that kept us safe, how that kept our patients safe. But unfortunately, time passes and then we forget all the good practices that we learned. When COVID was going around, we were all carrying hand hygiene products with us. We were cleaning our hands 36 times a day. But now, are we doing it really? Are we practicing respiratory hygiene? Are we wearing masks where they are needed? Now, wearing an N95 mask all the time in a hospital may not be a practical thing. But do we really need N95 masks all the time? So we need to know a little bit about airborne precautions, a little bit about droplet precautions, a little bit about contact precautions, because depending on these, the use of PPE is going to vary, isn't it? So if somebody has an infection which is airborne, we've all been through it, we know about COVID. What are the other airborne infections? We'll come to it in a bit. But those require much more isolation precautions and very rigid implementation of standard precautions. Let's talk about biomedical waste management. I've already told you that we need to know which waste goes where. When we finish doing our procedures, are we absolutely sure that we are disposing of our sharps properly, or are we leaving it there a little carelessly and then a housekeeping staff who's picking up after us is getting a needle stick injury and becoming sick as a result of that? So we need to know that it is our responsibility as leaders to make sure that biomedical waste is disposed of appropriately. Environment cleaning and disinfection, we see, those of us who work in oncology centers, we see that once a patient leaves and another patient comes in between, a lot of cleaning happens, especially in the transplant units. Rigorous cleaning protocols are there. Why? Because we need to keep our patients safe. So there should be protocols for spill management. There has to be protocols for wiping down surfaces clean. so that infections don't spread. What about safe injection practices to prevent infections? You have to know that hepatitis B, C, HIV, all of them are spread through unsafe injections. And we need to keep our patients safe by using one syringe, one needle, one time. You cannot reuse a syringe or a needle, even if it is for the same patient. Sometimes what we do, multi-use vials, we just leave a needle in and we drop injections for multiple people from that same vial using that same needle. That is not a safe practice. So for every patient, you have to use one syringe, one needle, once only. You cannot reuse it. Now I'm going to come back to my most favorite topic, and this has to be all of your favorite topic as well, and that is hand hygiene. So we have to know our 5 moments of hand hygiene, and those are before touching a patient, before doing any sterile procedure. So 2 befores, and there are 3 afters. After touching a patient, after exposure to body fluids, and after touching a patient environment. We have to remember our 5 moments of hand hygiene all the time, every time. Now, you might ask that, do we need to wash our hands all the time? How many times a day am I going to wash my hands? No, you have to wash your hands if they are visibly soiled. You have to wash your hands if you are practicing enteric precautions. So that means if the patient you have just touched has an enteric bug, say like Salmonella or even C. diff, you need to wash your hands after touching that patient. But the rest of the time, an alcohol-based hand rub is absolutely sufficient. If your hospital is not providing point of care access to hand hygiene products, which sometimes is not possible because a lot of our public hospitals are very, very crowded. There are so many people there that the management finds it impossible to give point of care access to hand hygiene products. Then I would say you carry your hand hygiene products with you. In your pocket, just keep a bottle of hand rub and practice your 5 moments of hand hygiene. I'm going to, because as I said, this is my very, very favorite topic, I'm going to come back to you with it once more later. But in the meanwhile, can we look at the next slide, please? Let us just quickly go over transmission-based precautions, isolation-based precautions, an easy guide for contact precautions. That means the bug is going to spread by touching the patient and then going and touching another patient through the hands. So hands have to be cleaned in between patients, and sometimes gloves need to be used. But remember something, if you're wearing gloves at work, it is for one patient at one time only. You cannot wear those gloves, then use hand rub over them, and then go and use them for another patient. Because over time, the gloves become really soiled, and it gives you a false sense of security because your hands are really not safe when you're just using gloves. For droplet precautions, we need to wear masks. So most of the respiratory viruses and meningococcus, which fortunately we don't see that much of, all of them are droplet viruses. So somebody who's got a rhinoenterovirus or a Boca virus or adenoviral respiratory infection, these are all droplet viruses spread through droplets, which are large particles, which do not travel far from the patient, and they go away from the atmosphere quite quickly. So a simple surgical mask will prevent droplet infections, and of course, hand hygiene. But what are airborne precautions? What are the airborne bacteria and viruses? Very, very important. Tuberculosis, measles, chickenpox, COVID, and avian influenza. If your patient has any of these, then you absolutely have to take airborne precautions unless you want all the patients in the ward to get it. So if a patient comes with chickenpox, even keeping that patient in a private room is not safe unless the ventilation of that private room is absolutely separate from the rest of the ward. Because these viruses and bacteria can stay suspended in air for a very long time, and they are so small they can travel easily for long distances without losing their viability. And that is why airborne precautions was what we all practiced when COVID patients were filling our hospitals, not just about 3 or 4 years ago. Now, what are the contact precautions? What will they prevent? They will prevent the multi-drug resistant organisms and extended drug resistant organisms from spreading from one patient to another. Also, what are the enteric bugs? As I've already said, bugs like Salmonella, Clostridium difficile. These patients, if you have isolation rooms, you have to keep them in neutral pressure isolation rooms. Or you can keep them in the open ward as long as you are meticulously practicing contact precautions. So if you have a patient with Salmonella in the open ward, then put up a board over there saying practice contact precautions. So wear gloves when touching the patient or doing any procedure, when handling the patient in any way. Discard those gloves safely after your procedure is done, and practice hand hygiene, hand washing for contact precautions with enteric bacteria after you've touched that patient. For all airborne precautions, airborne organisms, you have to keep these patients in a negative pressure isolation room. What is a negative pressure isolation room? The pressure within the room is less than that of the outside pressure. So when the door of the room is opened, outside air can enter the room. The inside air cannot come out. And we have to remember that here, the inside air is completely filled with whatever bug this patient has, and you cannot let it come outside and infect all the patients. What is positive pressure isolation? So many of you are transplanters, so I don't need to tell you about isolation precautions in a positive pressure room. When you're trying to keep the patient safe from all the bugs that are outside. So this is a reverse barrier. The patient's room has higher pressure of air, so when the door is opened, outside air cannot enter into the room because the pressure inside is higher. So all these barrier precautions that we do, these keep you safe and they keep your patients safe. Next slide, please. Aseptic non-touch technique, we are doing procedures all the time. We're performing lumbar punctures, we're doing bone marrow aspirations, we are doing biopsies, we are intubating some of us, we are placing IV cannula. So hand washing is absolutely a must before and after an aseptic non-touch technique. What do we have to remember? Wash your hands, dry them in air, don the sterile gloves properly. That means you cannot touch the outer surface of the glove with your ungloved hand. So we have to remember these precautions. If there are any surgeon friends that you have, they know all about this because they practice this so meticulously. The other thing we have to remember is key part and key site protection. Say somebody is doing a dressing of a Hickman line. So the key part is the line itself, and the key site is the chest wall where the line is exiting. So that has to be protected. The aseptic field has to be managed. So supposing you're doing an aseptic bone marrow aspiration or a lumbar puncture, you're giving intrathecal drugs, and somebody passes you whatever you need, maybe a syringe, over your aseptic field. That is poor practice because you can drop something, the field will become unsterile even before you know it. So your aseptic field has to be managed. Actually, infection preventionists, that means all of us who are in this meeting here today, we need to have obsessive compulsive disorder. I know all hematologists and oncologists do have OCD to some extent or the other, but this is necessary to keep you safe and your patients safe. Next slide, please. Now we hear quite a lot about healthcare associated infections. In my very first introductory slide, I said that it is our job as infection preventionists to make sure that no patient gets an infection in hospital that the patient did not already come with. If a patient comes with an infection to the hospital, you treat it. But the patient came to hospital for something else, and we give him an infection. That is something that has to be prevented. to the best of our ability. So what are the healthcare associated infections? These are benchmarks of a safe hospital because every hospital has to provide data about hospital acquired infections. It has to say in a month how many of these are happening because only by analyzing these we can find out how robust the IPC system in that hospital is. So what are these HAIs? Number one is CLABSI, central line associated bloodstream infection. Now, one thing you have to remember that the terms we are using here are epidemiological and surveillance terms. These are not clinical terms, absolutely not clinical terms. So all of us have patients who get bloodstream infections and they have central lines. Do they all have CLABSI? Maybe not. But when the surveillance person, so when the scientific officer or the infection control nurse is building up the surveillance data, they are going to follow the surveillance definitions of these infections. So one is CLABSI, the next one is CAUTI, that is catheter-associated urinary tract infection. So a patient has a condition which necessitates the introduction of a urinary catheter, and then the patient gets a UTI. So that would count as a CAUTI. Ventilator-associated pneumonia. If there are any intensivists in this audience today, then they would know more than anybody else how dangerous this is and how much it contributes to morbidity and mortality of patients. So this is something every intensivist fears and tries to prevent. Now, how do you prevent all these infections? Another thing is surgical site infections. A patient gets a surgery, a major or a minor one, and then the surgical site gets infected. And that means there is a problem either in the operation theater or in the post-operative care. And of course, transfusion transmitted infections, which are life-threatening sometimes. And all transfusion specialists who are present here today know how meticulous they have to be so that these things do not happen. Now, all these infections, you have to prevent them. And how do you prevent them? By meticulously adhering. I keep on using this word meticulous because that is what we always, as infection preventionists, have to be. We have to prevent these infections by adhering to standard precautions. If the standard precautions are adhered to, then these things are not going to happen. CLABSI is not going to happen. CAUTI is not going to happen. Surgical site infections do not happen. And to prevent these, what mostly our nurses do this, and what they follow are called bundles. What are bundles? Infection control bundles? They are a series of actions which, when taken together, form one action that keeps a patient safe. So for VAP, they will use VAP prevention bundles. So that is nursing the patient in a 30 degrees up position, oral care, suctioning. So these are the things that are used. Similarly, for CLABSI, they will use the line insertion and the line dressing bundles. For CAUTI, they are going to be using the catheter insertion bundles. For prevention of SSI, they are going to be using the dressing bundles. Sometimes we don't even notice how much these are happening all around us. If you just be a little mindful, you will see how rigidly people are following these things. That is keeping your patients safe. Next slide, please. Now, let's talk a little about ourselves now. We've spoken about patients. We've seen how we can keep them safe by adhering to standard precautions. But let us just talk about post-exposure prophylaxis. Despite all the care that we take, sometimes we can get a splash injury or we can get a needle stick. When these things happen, what are the infections we can get? Mostly and very scarily, you can get HIV infections or you can get hepatitis B or hepatitis C. If you get a needle stick injury, it has to be reported right away to whoever the supervisor is and to staff health, because the staff health is going to guide you. So how do you prevent these? You have to wash the area with soap and water and report immediately. Within 2 hours of exposure, You cannot get a needle stick injury and go home and come to staff health tomorrow and say, I was looking after that patient and such a patient. There was a used needle and I got a needle stick injury. And then what would staff health do when you report? The staff health is immediately going to check what the patient's serology status is. That brings me to another thing. Our patients, as hematologists and oncologists, our patients are chronic patients. They keep coming back. They are multiply transfused patients. So make sure that you have all the patient's serology at hand, that at diagnosis and probably in multiply transfused patients, every 6 months or so, you repeat serology for the patient for bloodborne virus infections. So once a healthcare worker gets a needle stick injury and it is reported, the staff health would look up which patient it was and whether the patient was known to be seropositive for any of these conditions. If it is an unknown patient, then the patient will have to be brought back, serology tested, so that the healthcare worker could get appropriate prophylaxis. For HIV, antiretroviral measures will have to be taken within 72 hours for them to be effective. And that would consist of drugs like tenofovir, lamivudine, dolutegravir, etc. for almost 4 weeks. So the best way is to be careful and to prevent needle stick. So dispose of sharps very carefully. Likewise, hepatitis B has to be reported within 24 hours. All healthcare workers have to be compulsorily immunized against the hepatitis B vaccine. And if there is very high risk exposure to hepatitis B infection, then hepatitis B immunoglobulin has to be given within 24 to 48 hours. Varicella zoster is a very, very common infection. When we were kids, it was just said, okay, you get it and you get on with it. But now we know that in immunocompromised patients, varicella zoster can be life-threatening. It can kill because these patients can get hemorrhagic chickenpox and they can die from it. And how is chickenpox transmitted in hospitals? It is usually transmitted through healthcare workers. In a recent study that we did, where we were looking after caregivers of children with cancer, and we serologically tested them when they were going into a long stay facility, what we discovered is 25% of the young adult population that we tested were non-immune to chickenpox. Chickenpox, there's a very effective vaccine against chickenpox, but it is not a part of the routine immunization in our country. So I would request all of you who are here in this talk today to find out whether you are seronegative for varicella zoster. You might be, you think you had chickenpox as a kid, but you don't know. You think you're immune, you may not be. So your hospital should have your serology records. If it doesn't, get yourself tested. And if you're non-immune, please take 2 doses of the vaccine, because this is a vaccine you cannot give to your patients. If you are safe, then your patients will be safe. Make sure that all the people you work with know about this as well, and they get immunized against chickenpox. If a patient gets exposed to chickenpox, then usually what do? You can either give them varicella zoster immunoglobulin, which is extremely expensive, or you have to give them prophylactic acyclovir for 3 weeks, which often you do not want to give because it's a nephrotoxic drug. And we know that as oncologists, all our patients are getting loads of other medications. And on top of that, we are adding a post-exposure prophylaxis for a preventable infection. Next slide, please. So, what are the immunization requirements for healthcare workers? We are talking about infection prevention over here. So, what is essential is the hepatitis B vaccine. Without hepatitis B vaccine and without seropositivity against hepatitis B, no healthcare worker should be handling patients where there are exposure-prone procedures. And what is recommended? That everyone has to be up to date with childhood immunizations. Some of us, we don't even know what childhood immunizations we got. But if there are young residents in this talk today, you can ask your parents whether they were all completed. If you're not sure, just take a booster. Pertussis is still quite common. Measles happens in young adults, so just take that. Influenza vaccine. The new vaccine is supplied by the World Health Organization, and it comes out in March or April every year. As soon as a flu vaccine comes out, make sure that you take it. You take it home to your families, especially if there are elderly people at home. Protect them and make sure all your patients receive the influenza vaccine every year while they are immunocompromised. But as healthcare workers, we have to take it every year. This is absolutely a no-brainer. You can't say that I don't like needles. I'm not going to take the vaccine. That is not good. You have to take this vaccine. And I've already spoken about the chickenpox vaccine. If you're varicella zoster virus IgG negative or non-reactive, this vaccine is a must for all healthcare workers. And in the COVID times, we were all given the COVID vaccines by the government. And we know that if nothing, this vaccine, it stopped COVID so that we are back to our normal lives today. Next slide, please. A little bit about exposure-prone procedures, all surgeries, dental procedures, and sometimes, we examine the inside of a patient's mouth. Patient has mucositis. We use our finger to open the mouth and see, especially if it's a child or something. Be very careful. It can be exposure-prone procedure because you can get an infection from there. So you, as a healthcare worker, you cannot perform any exposure-prone procedure if there is any of the following infections, that is HIV, HPV, or HCV, until staff health gives the clearance. Sometimes, inadvertently, we are seropositive for hepatitis B. Until we have taken adequate treatment with advice from the infectious disease specialist, we cannot perform any procedures. So we have to be honest about this to keep our patients safe. And whoever gets it must seek clearance from staff health and medical administration before they can be allowed to perform exposure-prone procedures. Because these healthcare workers have to be regularly followed up until they have an undetectable viral load. And they have to be monitored closely, not just for their own safety, but for the safety of the patients they are going to look after. Next slide, please. So a little bit about staff health. Again, we think that staff health is there to make life difficult for us. They keep on telling us, you can't do this, can't do that. But what does staff health actually do? So they look after our vaccination needs. When we first join, they perform serology and they have to maintain a record, because if somebody is seronegative for hepatitis B, it is the staff health's responsibility to make sure that that healthcare worker gets the hepatitis B vaccine. If we have infections, like a cough or cold or a rash, we need to go to hospital and report to staff health, because it may not be safe for us to go on working with our immunocompromised patients. If there's a needle stick injury, it has to be repeated immediately. We have already said. If you have gastrointestinal symptoms, a bit of diarrhea, okay, I think I'll just go to work. It is better to stay home, better to report to staff health that I'm not doing so well. And we, as healthcare workers who are looking after immunocompromised patients, we really should not go to work if we have respiratory symptoms. And if necessary, we have to report to staff health. Next slide, please. So again, I said I love hand hygiene, so I'm going to come back again to the 5 moments of hand hygiene. And I assure you, we are almost towards the end of this talk today. So the before moments: number 1, before patient contact. Number 2, before an aseptic task. Whatever you do before patient contact, you're doing your ward round, going from patient to patient. As I said, a hand rub will do, but the hand rub has to be appropriate. Check the constitution of that hand rub. It has to have 70% alcohol, because that is the only thing that works. Hand rub is also very good in other ways because it has got a residual effect. So it stays on the hand and its protective action does continue. So the before moments are before patient contact, before aseptic task. After moments are after body fluid exposure risk, after patient contact. And something that we almost always forget is after contact with patient surroundings. So touching the bed rail of the patient or the bedside notes of the patient or even the curtains around the patient's bed. After touching those, we need to practice hand hygiene. I think I'm going to end here. Uh, can we go to the next slide, please, and see if the video there works? This is just a bit of fun on a Sunday.
Ma'am, is there audio in the in there? Should I add the
Um, yes, there is some audio. Would that work?
Yeah, I'll just stop share and reshare again for that. Just a
Okay.
second.
Thank you so much.
Thank you, ma'am, for that fantastic and superb lecture. And especially the video made us, open up today. Thank you so much, ma'am. It was great. And I now request all our discussants to please put their raised hand signs so that we can start our question association with Dr. Arpita Bhattacharya, ma'am. Yes, so we have Dr. Shuhani. Please go ahead with your question.
Am I audible?
Yes, you're audible.
Hello, Arpita ma'am. As I always say, it was pleasure listening to you.
Thank you.
Ma'am, I have a question whenever a patient is admitted to us, a new patient, when we send the surveillance cultures, nowadays we find many of the patients at baseline, they have MDROs in stool. So, ma'am, how do we handle them? How do we keep them? And because in a government hospital, the wards are like one ward has six patients and they have to share the washroom. So, ma'am, how we take the precautions for those patients who harbor MDRO in stool at baseline?
Okay, stool surveillance for MDRO is a contentious topic. Okay, the transplant physicians would conduct surveillance for all their patients because it is really important to keep those patients who are the most vulnerable safe. But I think that if the patient is going to stay in a general ward and is not a transplant patient, then stool surveillance may not play such an important role. In most hospitals, unless patients are in private rooms, they have to share washrooms. So just teaching the patient a little bit about hygiene sometimes goes a long way. And I think if you can get your nurses together for a little session, train them so that whenever a new patient comes in, the nurse can talk to the patient because our patients come from all strata of the society and some of them have not even seen a proper toilet in their lives. So to teach them a little bit about hygiene will go a long way in preventing infection in your hospital, in preventing outbreaks of these enteric bugs.
Thank you, ma'am. Ma'am, another question. Ma'am, we avoid OPV in the younger siblings or the contacts who stay together in patients receiving chemotherapy. Ma'am, What should we suggest him for rotavirus vaccines of the siblings?
I am not sure because rotavirus vaccine is not given in the government schedule yet. So,
In our state,
yeah,
it's
is it now being given? Okay. So
ma'am, in
I
our
think,
state it's given. Yeah.
yeah, okay. So I think that if a sibling is going to be excreting that virus in the stool, that vaccine has to be withheld for the time being.
Thank you, ma'am.
Thank you.
Thank you, Dr. Suhani. Professor Dr. Vijay Tilak, your question, please. Dr. Vijay Tilak? Yeah. Yes. Please go ahead, Dr. Vijay Tilak.
And especially the video was really an eye opener. We really don't appreciate how dangerous it is, and really it was very nice. I just want to add to your talk, ma'am, that usually the needles, syringes, gloves, cotton are being disposed of and then they are being recycled. So I think one very important thing is that we should destroy the needle, the syringe. We should cut the gloves before disposing them so that these chances of being recycled are minimized.
Yes, I think, sir, you have a very, very valid point. And, I'm in West Bengal, and all of you must be knowing the intense turmoil that went on, is going on since
Yes, ma'am.
last August in our state,
Yes,
in
ma'am.
Kolkata.
Yes,
And the
ma'am.
principal of a medical college has been accused of recycling biomedical waste.
Yes.
And that is a reality because in our country there is so much rampant corruption. So now whether we can always do that, cut every syringe is a very difficult thing to do. But what we can make sure, or what our administration can make sure, is see that the biomedical waste is going to reliable. If it is outsourced, a lot of hospitals have take care of their own biomedical waste. But if it is being outsourced, just to make sure that they are reliable and transparent because this is a very, very big deal. How many syringes are being used in your unit every day? And syringes are hard things to really destroy. Needles, yes, there are needle cutters. You can cut the needles and then put them in. But syringes will be very hard to destroy, sir.
True, true.
Thank you, sir. Dr. Rashmi Kushwaha, your question, please.
Ma'am, I would like to congratulate you for a wonderful talk. And I have a question like there are certain genetic or molecular factors like neutrophil dysfunction or T cell dysfunction. So these also definitely affect the outcome in hematological malignancies when we consider the infections. So should we do something to evaluate these while considering the treatment protocol in hematological malignancies?
I think I'm not the best person to answer this because my talk is purely based on what we can do as infection preventionists. There are immunologists and very, very learned hematologists in this audience who would better answer that question. I'm a pediatric oncologist, I'm a solid tumor person. All our patients are immunocompromised. And what we, as their physicians, should do is prevent, to make a barrier so that one bug is not going from one person to another. That is what, just to prevent we have to assume that all our patients are going to get bad infections.
Right, ma'am. Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, Dr. Rashmi. Dr. Sonali Mohapatra, your question, please.
Good afternoon, ma'am. Ma'am, I just want to ask, do you follow neutropenic diet in the immunocompromised patients?
That is a very good question, Dr. Sonali. Neutropenic diet has been heard and unheard over the years. The
Because, ma'am,
overwhelming evidence now is if the
yeah,
patient is not a transplant patient, I'm not talking about transplant patient here. I'm just talking about general hematology and oncology patients.
yes, ma'am.
I
Any
would say
like
neutropenic.
patient, like a pediatric ALL patient in
Yeah,
induction in a general ward.
I understand. I understand. So non-transplant patients, just a clean and safe diet. that should do. Neutropenic diets means that, we used to say all sorts of things, that they can't eat fruits that cannot be peeled, and they cannot reheat food and things like that. But all that is really going away, because patients should be allowed to eat what they can, because as it is, and especially child patients, they become very picky about food. They don't like this, they don't like that. As long as the food is clean and it is safely cooked, fresh cooked food, that should do. Obviously, if a child wants to go and eat golgappa outside, you would stop that. But any other food should be good. Fresh home cooked food and all washed fruits should be fine.
Yes, ma'am. Because of late, like 2, 3 papers has come up that neutropenic diet really does not prevent this.
No, it does not prevent infections. No. But transplant patients, I'm not even going to talk about.
Yes, ma'am. And ma'am, another question is like our patients are really poor and they come from unhygienic conditions to the hospital. So do you practice like sending culture, blood culture or something when the patients you start try to start induction?
But if the patient has fever, neutropenia, you have to send a blood culture, isn't it? You can't.
Sometimes like the patient has come like history of fever 1 month or something, and that fever is really maybe related to the disease itself, like leukemia, the fever is there.
Yes, but how do you know the patient also doesn't have a bloodstream infection? You wouldn't know that unless you um, do a blood culture, isn't it?
Okay.
Quite a lot of the time, they have a prolonged fever, and that would be a disease fever. But in our unit, we practice taking a blood culture if the patient is not febrile. On arrival at the hospital, we will not take a blood culture. We will only take it if the patient is febrile. Not just if there's a history of fever, but the patient doesn't have a fever on coming to hospital on presentation, we won't send a blood culture. We will send it only when the patient is febrile.
Okay. Thank you, ma'am.
Thank you.
Thank you, Dr. Sonali. Dr. Rizwan Javed, your question, please.
Thank you, ma'am, for your enlightening talk. In fact, it inspired us to be preventionist now. So when we don the preventionist hat, and since many of the KPIs are associated with infection prevention, like central line infections and so on, it is important to have better compliances. Would you advocate training of staff as well as their performance in directly reflected upon the compliance, which could would be better henceforth, and maybe polite feedback thereafter, just to see we have better compliances for infection control practice and the culture of nurturing this?
Dr. Rizwan, that is an excellent question. Right in the beginning, we heard from our chief guest that infection prevention is a team effort. You or I cannot be infection preventionists in isolation. We have to do it together with our teams. And because the nursing staff, because the housekeeping staff are so intimately associated with patients, we doctors, we come and we go. We take our ward rounds and we go. Or in the outpatient, we just see the patient, and that's all the contact we have with the patient. But the nurse is there with the patient all the time. The nurses are on the floor all the time. The housekeeping staff, they keep on coming, cleaning. So they are far more in contact with the patients. And their reality is actually the reality, not ours. So I would say that a good infection prevention and control team will take everybody on board. And the thing is that it is human nature to suppress things that we don't really like to do. So infection prevention is one of them, because it is just another of those boring things we have to remember. So what happens is we tend to forget. And when we forget, how do we remember? Reminders in the workplace. So there are posters everywhere in the hospital that you work in, my hospital. There are workplace reminders everywhere because we have a very robust infection prevention and control program. So, hand washing before every basin, at every patient's bed. There are the safety first notices. So workplace reminders. So you've come to work, wash your hands. Use the hand rub. Point of care access. But in spite of this, people need reminding. So I would ask and request the entire audience that's present here today. When you decide that you're going to become a hand hygiene champion, it is also your job to remind others to practice hand hygiene. Now, you can't go fighting with your colleagues, but a gentle reminder. Now, it can become very awkward because a person who's senior to you in age or rank might not be practicing hand hygiene. A junior nurse telling a senior consultant that, ma'am, you have not practiced hand hygiene. We would think, "Oh, how can that happen? That's impossible, it'll never do." But that has to become the culture in all our hospitals. There have to be regular training sessions with the staff because, as I said, people forget, and reminders at workplaces, and reminding each other, buddy systems, that I remind you, you remind me. Are we practicing our standard precautions?
Thank you, ma'am.
Thank you, Dr. Javed. Dr. Shilpi, your question, please.
Thank you for the excellent lecture, ma'am. As in addition to Dr. Rizwan's comment and the discussion on hand hygiene, in our hospital, ma'am, we are practicing hand hygiene audit regularly. So an infection control nurse goes to the ward and ICU and OT, and they just observe the category of people like housekeepers, male, female, nurses, male, female. So like that, we are doing it regularly, and the results are displayed monthly. So whoever has got lesser high compliance, they are counseled, and the next month we see better compliance among that group. So this is one way to motivate people to do better hand hygiene, and that's all I wanted to say.
That is a very, very astute observation, Dr. Shilpi. All hospitals should have regular hand hygiene surveillance. And doing surveillance is not enough unless you're sharing the results. Whatever surveillance you're doing, be it hand hygiene surveillance, be it bundle compliance surveillance, be it surveillance for hospital-acquired infections, the results have to be shared with the stakeholders. And who is a stakeholder in hand hygiene? Everybody. So, but really, how many of us carefully go through these hand hygiene reports? Sometimes we see the doctors are the worst offenders.
Yeah, ma'am. In the first result which we saw, the male doctors were we had least compliance, and the
Yes.
nurses had better than
Yes.
them.
So, may I request whoever is present in this audience here today, if you just go online, there is a WHO hand hygiene tool. So go over that and put yourself through that exercise and see what resources you have and how well you're utilizing those resources. It's a very interesting thing to do, a good exercise. Do it with your teams.
Thank you, ma'am.
Thank you, Dr. Shilpi. Ma'am, we have some couple of questions from the audience. Dr. Ali Mahmood has a question. He wants your opinion on oral polio vaccinations in pediatric cancer patients.
Oral polio vaccination is now limited just to the government mass vaccination program. The routine vaccination of children is now IPV because it is safer and more effective. No child or no patient with cancer who's receiving treatment for cancer or is immunosuppressed because of any other condition should ever receive a live vaccine, because that can cause a life-threatening fulminant infection. Though these are attenuated bugs, but still they can cause life-threatening infections in somebody who's immunocompromised. So no OPV, no measles vaccine, no chickenpox vaccine.
Thank you, ma'am. There is one question which has come up from Dr. S.K. Sharma for putting up ordinary IV lines, not the central lines. Do you recommend sterile gloves or just simple disposable gloves, as there are cost implications?
Very, very good question. Very appropriate question, sir. Not sterile gloves. You wash your hands properly. You do, as we have discussed, site protection. So you clean the site properly, wear clean gloves, but wear those gloves because you have to be protected yourself. If you see anybody putting in an IV cannula without wearing gloves, stop them. But just clean gloves out of boxes would do. You don't need sterile gloves.
Thank you, ma'am. And just for respiratory tract infection, like for respiratory tract infection, one takes a 1 day off. Should we do it for if the patient has got diarrhea also?
Well, it is up to you, doctor. It is up to you. It is up to you. If you feel up to if somebody has got something like a bad respiratory infection, they should not really come into work in an oncology unit.
And for diarrhea, it's okay.
Oh, well, as I said, it is up to you. But if it is a bad infective diarrhea, then maybe a day's rest. You wouldn't keep running during your clinic, would you?
True. Dr. Satish Kumar, your question, please.
Yeah, thanks, Dr. Amit. Thank you, ma'am, for that enlightening talk. So I had a question. If there is a patient with MD or UTI in the ward, in general ward, what precaution do you advise apart from hand hygiene and things? There are several patients who use the same bathroom. So do you want to shift them to a single room, or what precautions should we take, ma'am?
No, just contact precautions.
Okay, if the other patients use the same washroom, is that okay?
That's okay. That's okay. But contact precautions.
Contact
Because you
precautions.
see, you are getting, say you've got a E. coli urinary tract infection. You don't know that the patient's body surface is also not colonized. So you're touching the patient, say you're examining the patient's abdomen. Practice hand hygiene before and after.
Just regular contact precautions.
Yes.
And do you advocate surveillance cultures for patients going to BMT?
I think I would leave that up to the transplanter.
Okay.
Because different units have different practice. But as far as I know, all transplant physicians like to have surveillance cultures.
Right. Thank you. Thank you, ma'am.
Thank you, ma'am. I've finished all the questions from the audience. Any discussion want to ask any other question? So anybody wants to comment, advise, what do you feel like? Okay. Dr. Sonali, any other question you have?
Hello, I'm Dr. Narendra.
Yes, sir. Please go ahead.
From Delhi. I have a comment and experience to share here, especially in this meeting of how to prevent infections, that I'm regularly treating patients with hematological malignancies and doing transplantation. And we are following this hygiene norms of the diet. We are not, following any neutropenic diet protocol. So we allow patients everything, including every kind of fruit, vegetables, salads, and but what we have seen that whenever patient break the rule of not eating any street food or any restaurant or hotel food, they usually get infections. So I think this is most important to stress with the patient that they should always 100% avoid any street food, any food coming from a even from a good restaurant or a good hotel. So that is, I think, a rule which has to be followed. So that's my experience. I have seen almost everybody coming with infection having a history of consuming something from street or outside.
True. Very true, sir. Thank you so much. Dr. Surya Ghosh, you have a question?
Hi. So actually, continuing on the question on surveillance cultures, there were two questions put forward in this meeting today. So with regard to surveillance cultures in transplants, as a unit, we do recommend that because we have seen that having surveillance cultures helps us escalate antibiotics earlier. We've done an audit and we have published that data, which has shown concordance with the subsequent blood cultures, which have flagged the same organism with the same genotypes as that in the stool of that patient or the throat of the patient. So in the transplant setting, when the patients can deteriorate very rapidly, and when we have ways to isolate the patient and not in a common general ward, we are better off sending surveillance cultures and acting on them. In terms of general ward patients and in terms of surveillance, the incidence, most of our patients who are treated at oncology centers do end up having a lot of MDROs because of repeated admissions and repeated rounds of antibiotics. So it is difficult, but it helps in these critical situations where we can escalate antibiotics and guide the empiric antibiotic policy of the patient. So that is my take on surveillance cultures. And I have actually discussed another topic in multiple infection control meetings in our own institute as well. With regard to vaccination for COVID, we have no policy so far from the government for vaccinating post allogenic transplant patients with COVID vaccine. It is not available in the market. So as a fraternity of oncologists and hematologists working all over the country, we may approach the government to form guidelines to at least have COVID vaccines available for post-transplant patients. Also, an entire generation of subsequently,
Children.
let's say, yes. So if you have a child right now who wants a vaccine, you cannot vaccinate because that vaccine is no longer available. So these are things which are followed in Western countries. COVID is the first vaccine which is given to a post-allo transplant patient, that is something we can adopt in the country as a whole.
True. Very true. Thank you, Dr. Ghosh. There is one question which has come up from Dr. Gauri. Do commonly used objects like ward phones and door knobs need any particular attention or surveillance, ma'am?
That is an excellent question. There are things which are called high touch surfaces. Okay, so doorknobs, absolutely. Our mobile phones are crawling with bugs. So, say the doorknob of a washroom. A patient uses a washroom, uses the doorknob, comes out, and does or does not wash his hands. So you can imagine how infected that doorknob might be. So hospitals should have good policy for repeated cleaning of high-touch surfaces. And mobile phones should not be allowed in doctors' or nurses' pockets at all, because they are the worst offenders.
Absolutely, ma'am.
Ma'am, yeah, same goes for ornaments. So
Oh yes,
we should
people wearing rings
not wear any
and
rings or
watches.
anything.
That we should and long fingernails and painted
Yes,
fingernails.
yes, yes.
So for our women colleagues, I mean, all women hematologists and oncologists have forgotten fashion.
Absolutely. Thank you so much. Any other discussants want to ask any other question?
May I just make one comment based on what Dr. Shojo just said? Because he said about escalating antibiotics. One very important part of infection prevention is antimicrobial stewardship. Okay, so he said that patients keep on coming to hospitals, they get exposed to more and more antibiotics, and that is why they get MDR, which is absolutely correct. So we have to remember as a community that there are no new antibiotics. The patients are not going to die from the cancer because all sorts of cancer research is happening, but very little research is happening by way of new antibiotic discovery. So our tap has literally run dry. So you have to prevent infections and practice antimicrobial stewardship because our lives depend on it, really.
Absolutely, ma'am. I totally concur with that. Totally. Absolutely.
Thank you, ma'am. Well, so there are no more questions from the audience, and there are no more raising signs. Well, ma'am, thank you so much for that fantastic and lovely talk. It was eye-opening for all of us, and specifically that video which you showed that really changed our mindset today. Thank you so much. And even I thank all the audience as well as discussants to participate in this webinar. And I hand over to Pastor Victor for the final vote of thanks.
Thank you. Thank you so much.
Thank you.
Thank you so much, Amit sir, and thank you so much, Arpita ma'am. As sir said and everyone else mentioned that video was really eye-opening. That if we could see bacteria, then we would realize how important these smaller hygienic techniques are and how important it is to maintain that hand hygiene. Thank you so much, ma'am, for such a wonderful session. And I would like to thank Dr. M.B. Agarwal sir once again for providing us this platform. And see you all to the next session. Thank you so much.
Thanks a lot.
Thank you. Thank you. Have a good Sunday. Bye.
Thank you.